Department of Pediatrics, North Colombo Teaching Hospital, Faculty of Medicine. And she is the acting consultant neonatologist at Professorial Unit, Colombo North Teaching Hospital, Dr. Sangeetha Wickramarathna. I cordially invite Dr. Sangeetha to deliver her presentation.
Thank you. Thank you for that kind introduction. So actually, the first part of the presentation was ideally supposed to be done by Dr. Ruwan Silva, who is the consultant obstetrician of the Colombo North Teaching Hospital. But for some technical problem, I had to start with. I know the newborn component must have been at the second part after the antenatal management. Anyway, I would like to start with the management of the hemolytic disease of newborn component, although the antenatal management would be discussed later by the other speaker. So this is I think our society has decided to discuss this topic because it is very important and very commonly encountered in our setup. So there will be just yes, so this will be the outline of my discussion. And there will be a small introduction to the condition with the terminology and the pathophysiology slide, some more actually the pathophysiology of the newborn hemolytic disease would be discussed by myself, and the investigations which are supposed to be done postnatally, and the management of the postnatal period if a newborn is diagnosed with hemolytic disease. So as for the introduction and the terminology, early days, this was called erythroblastosis fetalis, and now the newest terminology is the hemolytic disease of the fetus and the newborn. So because the pathophysiology involved mainly the fetal period, we are usually probably the terminology has been evolved into the hemolytic disease of the fetus and newborn both. For the today's content, I would be discussing about the newborn, and the fetal component will be discussed by the other speaker. So basically the pathophysiology, we all know, involves the transplacental passage of maternal antibodies directed against paternally derived red blood cell antigens. So the hemolytic disease of the newborn actually involves all the type of incompatibilities, including Rh, ABO, and the minor group incompatibility. Although now today, for today's discussion, Rh incompatibility will be the major part that we'll be discussing under the hemolytic disease of the fetus and newborn, although it is the commonest etiology. So here, because of this transplacental passage of maternal antibodies, there will be increased RBC destruction, which will be discussed in the next few slides, of the infant, maybe resulting in a different set of clinical features. So we all know Rh incompatibility, it is the Rh antigenic determinant is genetically transmitted from each parent, from the mother and the father. As you can see here in this graph, this end has the maternal factor, maybe it can be either positive or negative Rh, and the father also can be Rh positive or negative, depending on that the fetus or the baby's Rh group will be determined. But you know, mother can be heterogeneous or homozygous, heterozygous or homozygous. Both can be dominant alleles or can be even non-dominant alleles. So like that father, if the father is heterogeneous, there's a risk of having a baby, only a 50% chance of having a baby who is having Rh positive factor. And if the father is homogeneous, there is a 100% chance. So here this picture shows what is the pathophysiology of the RH incompatibility in the fetus, which will be discussed in depth by Dr. Ruwan Silva. And here, the first pregnancy, if the mother is RH negative and having a fetus which is RH positive, there will be some minor or major sensitizing events. That means the blood mixing from the fetus to the maternal circulation. So during the first pregnancy or any kind of a miscarriage or some sensitizing event, there can be RH positive antigens going into the maternal circulation and formation of RH antibodies inside the mother. So the first pregnancy, there will be no much of effects because these RH antibodies initially starts forming as IgM antibodies, which they don't cross the placenta readily. So IgG crosses the placenta readily. So most of the time these sensitization events take place towards the latter part of the second trimester or the third trimester, and IgM antibody formation followed by IgG antibody formation. So IgG antibody formation takes some time. So the first pregnancy, it is really unlikely for the fetus to get affected. But as you can see, during the mid period between the two pregnancies, mother is anyway having anti-RH antibodies which have been already formed during the first pregnancy. And these antibodies will last long because they are IgG. And during the second pregnancy, if the baby is again RH positive, these antibodies will cross the placenta. Even without any sensitization event, they can go and cause hemolysis inside the fetal system, causing clinical problems, which we'll be discussing in the next coming slides. So here the pathophysiology, the typical scenario, as I have already discussed, there will be small quantities, usually even more than 1 milliliter of small amount of blood going to the maternal circulation from the RH positive fetus will be enough for the sensitization. And these events can be very small and very short lasting, but still they can cause sensitization. And these smaller doses stimulate the increased levels of antibody titers inside the mother. And there will be IgM, I already discussed initially, which will be changing into the IgG antibody with time. And they will readily close the placenta and causes hemolytic manifestation, especially during the subsequent pregnancies. So the RH incompatibility occurrence depends on multiple factors. Here the parity comes first. I already discussed the first pregnancy, it is less likely because it takes time for the IgG to form and cross the placenta, again go into the fetus and cause hemolysis. So therefore, it is less likely in the first pregnancy, but severity will be getting worsens with successive or subsequent pregnancies. And then due to repeated immune stimulation and sensitization events, the antibody titers will be also higher with time, so that the severity increases. The frequency of feto-maternal transfusion also determine the occurrence of RH incompatibility. Actually, we are worried about RH negative pregnancy in each and every mother as clinicians, but only 50% of pregnancies will have sensitization events. So even though they get sensitized, the required antibody titers will be less in some pregnancies. So even less than 50% of pregnancies, fetus will show some clinical signs of hemolysis. So the other thing is the allele frequency of the RHD antigen. We already discussed heterozygous fathers who are having a dominant allele, only one dominant allele, they will have only a 50% chance of having a fetus who is RH positive. And also the coexisting ABO incompatibility, that is interesting. The RH negative mother is partially protected against sensitization if they are having ABO incompatibility, because there will be hemolysis due to ABO incompatibility, which is readily happening before the RH sensitization. When there is a sensitizing event, when the fetal blood enters the maternal circulation, If it is already having ABO incompatibility, those red blood cells will be destructed readily due to ABO incompatibility. So there is no chance of getting stimulation for a Rh antibody formation. And definitely the smaller family size, when there is only 1 or 2 kids, there will not be any severe occurrence of Rh hemolytic disease of newborn. So that is the basic pathophysiology which is important for our setting as neonatologist. And the epidemiology wise, Rhd and antigen incompatibility is 3 times more common among whites. That is due to the difference of Rh allele frequency. And 85% of Caucasians are Rh positive, while 99% persons from Africa and Asia are Rh positive. So there you can see that is common among whites. And still the incidence of Rh incompatibility causing hemolytic disease in the newborn is around 3 to 80 per 10,000 neonates per year. So that is a significant amount. Still, this study was done in 2020, and still they have shown that this is despite all the measures which are taken by the obstetricians to prevent the disease and also to treat by the neonatologist, still the prevalence is much higher. So the clinical features for the newborn, I told you the basic pathophysiology what we have to take into mind is the hemolysis. So the fetus will have hemolysis starting from the antenatal period if we don't prevent it, and then the clinical features will be eminent after the birth. So antenatally also there can be some findings that will be discussed by the next speaker, and the newborn findings will be discussed here. So the severity of the clinical features are actually also variable. I told you only 50% pregnancies will have sensitization, even less than that will have clinically significant hemolysis. So now here the only laboratory evidence of mild hemolysis will be eminent in most of the pregnancies, and severe anemia with compensatory hyperplasia of erythropoietic tissue, that is massive enlargement of the liver and spleen, also will be seen. Even antenatally could be diagnosed with the Doppler studies and the ultrasound scan findings. And some fetuses will have, now when the compensatory capacity of the hematopoietic system exceeds, despite the enlargement of the liver and the spleen, still if you couldn't compensate for that severe anemia, there will be profound anemia causing pallor in the newborn, which will be seen just after birth, a pale newborn. And if the anemia is so much severe and profound, there will be signs of cardiac decompensation. That is the most severe entity that you will see in a newborn who has got affected due to hemolytic disease. So there will be cardiomegaly, respiratory distress, and also massive anasarca, that means generalized edema and circulatory collapse. So as a result of this cardiac decompensation due to profound anemia, we will see hydrops fetalis after birth. The picture shows how the newborn will look like. This is the most severe entity. So there will be the hydrops fetalis definition we might be knowing, and excessive abnormal fluid accumulation in 2 or more fetal compartments. So the potential spaces such as the pleural cavity or the peritoneal cavity or subcutaneous tissues, you might see 2 or more spaces, you will see excessive fluid accumulation causing skin edema or pleural or pericardial effusions, or even peritoneal, that means ascites, or amniotic fluid amount will be increased. So as a result of that, you will see this kind of a newborn just after birth. So nowadays it is commonly diagnosed during the antenatal period because of the improved obstetric care. So that this will definitely most of the time frequently results in death in utero or shortly after birth. So we will have to prevent this happening by implementing the preventing measures during the antenatal period. So the severity of hydrops depends on the degree of anemia we already discussed, and the level of serum albumin, because it will be So there will be hepatic congestion due to the cardiac failure, causing hepatic dysfunction as well. So there will be reduction of albumin production as a part of liver failure, and that will also contribute to the reduction of oncotic pressure and third spacing inside the fetus. Or the heart failure. So the ultimate thing will be the heart failure. It will also may increase the right-sided heart cardiac pressures with the subsequent development of edema and fluid accumulation in the potential spaces. So at the end, there will be left heart failure also, causing pulmonary edema and bilateral pleural effusions. So this will result in failure to initiate the spontaneous effective ventilation and ultimately birth asphyxia. So as neonatologists, what we will have to focus on will be to prevent or support the babies who are having failure to initiate the spontaneous effective ventilation, and also to support to them with the required resuscitation and treatment modalities which is available for the severe hemolytic disease of the newborn. So the other clinical features other than this anemia and the hemolysis anemia and the cardiac failure and the hepatic congestion, the jaundice is the most common visual finding that we will see during our neonatal examination. So the visual assessment of jaundice, this is the Kramer criteria which have been given in our newborn care guidelines. But the problem is we are being an Asian country, so the black bit of a dark skinned people will might not see during the visual assessment. This will be very unreliable in our setup. So you can assess visually, especially before starting phototherapy, but that will be unreliable. Still, you will have to keep an eye on the baby's other clinical features to prevent the severe disease, occurrence of the severe disease and its complications. So the rest of the clinical features, as the jaundice may be most of the time will be absent at birth, you might be knowing by experience effective placental clearance of the lipid soluble and unconjugated bilirubin. So there will be absence of jaundice at birth, but we will be keeping an eye on the babies who will be born to mothers with Rh negative or the prone to Rh incompatibility. And severe cases, there will be bilirubin stained amniotic fluid because the placental clearance also not sufficient for the higher production of bilirubin, causing cord and vernix cassia also stained with amniotic fluid. And the jaundice usually in initial 24 periods, it is the always pathologic type of jaundice we call it. So if a baby is jaundice during the first 24 hours, that is called pathologic jaundice, and we will have to act fast to exclude other differential diagnoses and also to treat the massive hemolysis and the high level of bilirubin. So the indirect reacting bilirubin is the one which accumulates during the pathophysiology due to hemolysis. This can accumulate postnatally and cross the blood-brain barrier, and they can get deposited in the basal ganglia, causing bilirubin encephalopathy, which is also a significant part of the pathophysiology of this illness and is the most worrying complication. So that is called kernicterus. So the acute bilirubin encephalopathy, which is called kernicterus, has 3 phases. Early phase, which will be 3 to 5 days, first 3 to 5 days of the illness, they will be presenting as very non-specific symptoms like lethargy, poor feeding or poor sucking, and slight hypotonia with a high-pitched cry. But intermediate phase, at the end of the first week of the life, there will be moderate stupor, irritability, fever, hypo or hypertonia. So there will be some postural abnormalities as well. But the most the end of the spectrum, that is the late phase, where the baby will be in deep stupor or coma with maybe having high-pitched cry, pronounced retrocolis. You can see here the baby is turned the other way around and there is opisthotonus, no feeding, and can have seizures in the 50% of cases, and imminent hypotonia will be there. So it will be gradually evolution will be towards the cerebral palsy, where it will be chorioathetoid type of cerebral palsy in latter part of life with hearing and visual impairment. So there can be petechiae, purpura, and thrombocytopenia. So just for your knowledge, and also can be hypoglycemia in severe hemolytic disease of newborn. So the postnatal investigations we routinely do. Any mother who is having Rh negative blood group during the antenatal screening, there will be cord blood taken for the hemoglobin and also the bilirubin levels and the direct antibody test. So other than that, you can do the reticulocyte counts and a blood picture where they will show polychromasia and nucleated RBCs. So there will be leukocytosis and thrombocytopenia as well in some cases. And the cord bilirubin, usually if it is more than 5 milligrams per deciliter, we start treatment for the babies. And despite the direct or indirect fraction, because the antenatally some treatment modalities such as intrauterine transfusion can cause even direct hypobilirubinemia during the early phases. So the indirect bilirubin content rises rapidly to high levels in the first 6 to 12 hours of life. So there will be a definite need of more frequent monitoring. So that you know how to do the direct antibody testing, where you will be adding some solution with antibodies. So that is called Coombe reagent, and where you will see agglutination with the patient sample. So if it is positive, there we take it as high level of immune mediated hemolysis. That is a significant one where you have to be alert. So goals of treatment. So we know what are the investigations that we have to do, and then the goals of treatment comes to prevent the intrauterine or extrauterine death from severe anemia and hypoxia. That will be during the initial period where you have to resuscitate the baby successfully. And then to prevent the neurodevelopmental damage due to hyperbilirubinemia and to avoid neurotoxicity as well. So the postnatal management, during the initial period, there have to be a skilled physician at birth, and we have to get ready with the irradiated group O Rh negative blood, which is cross-matched against the maternal serum. So if leukoreduced blood is the best for immediate needs of any transfusions. And if there is severe hemolytic anemia at birth, resuscitation definitely needed with supportive therapy, and might need a small transfusion of compatible red cells before going into exchange transfusion if the baby is having significant pallor, and also for volume expansion or to treat the hypotension. So the management options, basically we know there are 3 management options. Most of us know phototherapy and exchange transfusion with IVIG. So the treatment threshold graphs, we know from practice, we have graphs from 24 to more than 38 weeks of gestation. These are being provided in the newborn care guidelines, appendixes as well. So we have to plot the bilirubin levels from micromoles per liter through the against the age of the baby in hours. You have to be precise when you are marking them on this chart, because there are 2 levels, phototherapy level and the exchange transfusion level. So here the first line treatment is the phototherapy, we know. What is the effect of phototherapy is the converting the bilirubin to a water soluble form and eliminates it via urine. So that is, and also feces. So that is the basic mechanism of action of phototherapy. And the first line treatment, American Academy of Pediatrics, they recommend in 2014 guidelines, 2004 guidelines, which is the last update. And they say it is intensive phototherapy. That means at least 30 milliwatt per body square meter per nanometer is delivered to as much as of the infant surface area. So that is the irradiance they recommend. So the wavelength is around 450 to 470 nanometers. And we have currently the fluorescent lights and the LED lights. Currently much use is the LED light, where the less of the complications such as the temperature problems and the dehydration. So the distance differs depending on the fluorescent light or the LED. LED usually 10 to 15 centimeters away from the baby. But the fluorescent light, because of the high temperature or the heat production, you have to be a bit far away, nearly 15 inches, 45 to 50 centimeters. So you have to provide the baby with eye shield to cover the eyes to prevent the retinal damage due to the intense phototherapy, and improve the exposure with the very small diaper we have to put, and do frequent positional changes, and the monitoring of the baby with bilirubin levels as well as the temperature and other vital parameters. And the side effects, actually there are no much of serious side effects. There can be some development of loose stools, greenish color due to the byproducts of phototherapy. Other than that, there are no significant side effects. So the supportive care we have to provide with hydration. If the baby is on single phototherapy, you can even continue the breastfeeding, and even double phototherapy cup feeds with the express breast milk you can provide. And in extreme cases might need intravenous hydration. And monitoring, we have to do more frequent serum bilirubin levels, total bilirubin, and plot it against the H and see how the progression goes up. And when to omit the phototherapy, the guideline says, most of the guideline says, if it is very high levels, just below the exchange level, we have to do more frequent 2 to 3 hourly estimation of serum bilirubin, but otherwise 4 to 6 hour estimations would be enough. So when to escalate, we'll be discussing. So the indications for continuous double surface phototherapy is if the bilirubin level is rising more than 0.5 milligrams per deciliter per hour, or the or the level is within the range of 50 micromoles per liter below the exchange transfusion level, or the bilirubin fails to respond to single phototherapy. So that depends on your monitoring parameters. So the second mode of treatment is the exchange transfusion. Although we are not using it much, still we should know as neonatologists how to go for exchange transfusion. So the indications, exact indications will be if the total bilirubin remains in exchange transfusion range as per treatment threshold graphs, despite effective phototherapy. So if a baby's serum bilirubin level is very much closer to exchange transfusion level within the range of 50 micromoles per liter, you have to start double phototherapy and frequently monitor 2 to 3 hourly monitoring of serum bilirubin. If that fails to come down with your treatment, you will have to go for exchange transfusion level. So the other indication would be if the features of bilirubin encephalopathy is there. We know we already discussed what are the clinical features. That will be a definite indication for immediate exchange transfusion. So there are complications, immediate and late, which we'll be discussing later. So the exchange transfusion, O negative packed cells suspended in AB positive plasma is the ideal. And you can use O negative whole blood or cross-match baby's blood group, but the ideal would be O negative packed cells. And the double volume we use, and the use of acid citrate dextrose or citrate phosphate, and it should be fresh blood, which is less than 5 days old. And the umbilical vessels are the preferred route of transfusion, and monitoring of vitals and the blood gases, electrolytes, especially calcium, and the coagulation profile is very important during the process and also after the procedure. So the exchange transfusion complications we have to know, because it carries a lot of complications, immediate and late. So the catheter related ones and infections, hypocalcemia, thrombosis, hemorrhage, and hemodynamic instability, and the risk of necrotizing enterocolitis as early ones. And also there can be problems or complications related to portal vein thrombosis in later life. So the exchange transfusion have a mortality rate up to 5% according to the American Academy of Pediatrics guidelines. So the other mode we commonly use is the intravenous immunoglobulin, but the problem is it doesn't have much evidence. So the fractionated blood product, IVIG, manufactured from multiple donors and virally inactivated, it is said to be. Mechanism is it blocks the IVIG goes and blocks the FC receptors and prevent the hemolysis. The antibody is being coated and the hemolysis is prevented, enhancing the clearance of maternal antibodies from the circulation, and also lowering the circulated unconjugated bilirubin levels. but the dose we recommend to use, the guideline says 0.5 to 1 gram per kg over 2 to 4 hours. So it decreases the need of exchange transfusion is a controversial topic. So we has to be used for isoimmune hemolytic jaundice, which is proven by that and the retic count or the blood picture. And side effects reported in newborns will be apnea, hemolysis, and a higher incidence of necrotizing enterocolitis. So this, when the risk versus benefit is measured, and also the evidence. So this is the latest evidence available for intravenous immunoglobulin, which is this systematic analysis, and also it's like a development of an international guideline, which with an expert panel, which has been done by the British Society of Hematology in 2022. So it says the studies, they have considered nearly 148 studies, and they have come into the conclusion that the immunoglobulin treatment is not routinely recommended for immune-mediated hemolysis in newborns, either ABO or RH, because these studies have been more biased, and also the number of participants or the patients has been much less, and the risk versus benefit also they have measured and decided that there are no much of evidence for the use of intravenous immunoglobulin for the treatment or to delay the exchange transfusion or to reduce the need of exchange transfusion. So they have not shown any reduction of levels of bilirubin or the exchange transfusion rates or the hospital stay. So that means actually we have to think twice when we are using the IVIG in our setup also with this crisis, this much of a costly product. Are we to use it or not is up to us to decide depending on the evidence. So when to discharge? So as I told you, we have to monitor the baby's bilirubin levels. If they are coming down, we can monitor it 6 to 12 hourly. And once the bilirubin levels are 50 micromoles, more than 50 micromoles per liter is below from the phototherapy level, we can omit it. But still always, because it is due to RH negativity, we will have to do a rebound level after 6 to 12 hours. If it is also going down or static, we might be able to discharge the baby. Still, the babies who had neurological outcomes, neurological problems, definitely will have more frequent monitoring and follow-up with early developmental care. So that was the end of my presentation. I know the pace was a bit higher because I had to cover a lot of content and I had to do it at the beginning before the first speaker who was supposed to do the first part. So any questions related to the newborn management? Or else, if there are no questions, we'll be going to the next component of the discussion. So the summary, we already have discussed RH incompatibility can cause severe illness with complications such as kernicterus. And early detection, timely management is crucial. Prevention will be discussed in the second part of the discussion. And the management options, we had phototherapy, exchange transfusion, and IVIG, although the evidence are not much supportive for IVIG. So these are my references, national guidelines and the Nelson's textbook and the international guidelines which have been recently developed for the IVIG use. Thank you.
Thank you very much, Sangeetha, for your lecture. Now we have the second speaker. He's a consultant obstetric and gynecologist at North Colombo Teaching Hospital. He also the treasurer of Perinatal Society of Sri Lanka and member of NMRA for last 4 years and a member of specialty board for Critical Care Postgraduate Institute of Medicine. And he was the former treasurer of College of Obstetrics and Gynecology. He is Dr. Ruwan Silva. I cordially invite Dr. Ruwan Silva to deliver his lecture.
Thank you very much, Dr. Jit, for your kind introduction. So So how am I going to, Deepal, how am I going to share my presentation?
Dr. Ruwan, I think you can start to screen share your presentation. Sangeetha, you can exit.
Right? I hope you can see my presentation.
Yes, we can see.
Yeah, thank you very much. Actually, extremely sorry. So I had a technical problem at the beginning, so I could not join as a first lecturer. But anyway, Sangeetha, my colleague, uh, uh, thank you very much, Sangeetha. You made my task bit easy because you started and you discussed in detail the management of uh, hemolytic disease of newborn. So my task today to discuss RH immunization, basically obstetrician's role to improve the perinatal outcome of this disease. This baby is having hemolytic disease of newborn. This was a challenge for neonatologists, and it was a common problem quite some time before. So this data from Western world, hemolytic disease of newborn was very common prior to introduction of anti-D immunoglobulin. The incidence was around 16%. After starting routine postpartum prophylaxis, that is the injection given after delivery, hemolytic disease of newborn dropped to around 2% in Western world. Further reduction achieved in that part of world up to 0.28% after introduction of antenatal prophylaxis. So basically, with the introduction of antenatal and postpartum prophylaxis, they achieved reduction in mortality associated with hemolytic disease of newborn from 46 per 100,000 births to 1.6 per 100,000 births in Western world. Therefore, National Institute of Clinical Excellence in UK released guidelines in 2002 and 2008 recommended all negative mothers who do not have anti-D immunoglobulin should be given an additional dose of anti-D immunoglobulin in the third trimester antenatally. Unfortunately, in our health sector, in our health setup, still we could not introduce this to our local guideline solely due to financial burden we are experiencing as a poor country. But I think way forward, we should take some actions. We should take some steps to introduce this antenatal prophylaxis to our system, to our government health system, into our protocols to achieve reduce mortality rates due to hemolytic disease of newborn due to RHI isolation. Therefore, I think most of these topics Sangeetha has covered, but anyway, I will touch. So I want to discuss what is RH disease and a little bit of pathophysiology, management of RH disease in obstetric point of view, and bit of details about RH immunoglobulin. So let me start with very basic thing. What is blood group? The term blood group usually refers to an individual's combination of red blood cell surface antigen. Antigens are specific sites on different proteins, glycoproteins or glycolipids that form parts of the red blood cell membrane, which the immune system can interact. So these proteins have numerous functions such as membrane transporters, receptors, adhesion molecules, complement regulatory glycoproteins, structural component, so on and so forth. So this red blood cell nicely describe different which carry different antigens. So these antigens are responsible for different blood groups of human being. So out of all these blood groups, such as ABO system, Duffy blood group, Kelly blood group, Lewis blood group. So what we are going to discuss today is RH blood group. So RH factor or RH antigen is a surface antigen you find on erythrocytes. The term rhesus or this RH factor was coined since it was first discovered in rhesus monkeys in 1940. Rhesus monkeys are old world monkeys where Landsteiner and Weiner observed that injection of blood from a rhesus monkey into rabbits cause an antigenic reaction in the rabbit blood. So that is the story behind finding of RH factor. Very simple way. A person can be RH positive or RH negative based on the presence or absence of D antigen on the surface of red blood cells respectively. So if you concentrate on the right hand side, RH positive blood group, you see red blood cells carry D antigens. RH negative red blood cells does not have D antigen. RH blood group system consists of multiple antigens, actually over more than 50. Capital D, capital C, simple C, capital E, simple E. D antigen is mainly responsible for RH disease because due to very high immunogenicity. So my colleague Sangeetha explained RH hemolytic disease or RH incompatibility causing problem to the baby. So this RH incompatibility is a condition that occurs when a woman with RH negative blood type is exposed to RH positive blood cells, leading to development of anti-D antibodies by a process called isoimmunization. These maternal alloantibodies, IgG immunoglobulin, which persist for life and move freely across the placenta, causing fetal circulation during subsequent pregnancies when they lead to destruction of fetal erythrocytes after forming antigen antibody complexes with their surface D antigens. This results in alloimmune hemolytic anemia in the fetus, which is already discussed by Sangeetha as erythroblastosis fetalis. The severity of this illness depends greatly on the number of immunoglobulin, gestational age, and enzymatic activity of the fetus. So going into detail, the prevalence, 276 neonates per 100 live births per year are affected globally, even though the figures are very good at Western world. So the figures especially in developing countries are not that good. 50% of all fetuses with hemolytic disease of various etiologies died of Kernicterus or hydrops fetalis. The risk of death and stillbirths are 24% and 11% respectively among these affected newborns, while 13% of affected neonates develop Kernicterus, with the highest reported mortality rates in the Eastern Europe, Central Asian region, about 38 deaths per 100 live births. But the presence of coexisting ABO incompatibility decreases the incidence of this hemolytic disease drastically because of the presence of anti-A, anti-B antibodies against the fetus in maternal serum. So when we discuss about etiology of Rh hemolytic disease, so exposure of an Rh negative pregnant mother to Rh positive fetal erythrocytes due to following incidents will initiate the Rh immunization. Fetal-maternal hemorrhage during pregnancy secondary to normal delivery or cesarean section. Spontaneous or induced abortion, ectopic pregnancy. Antepartum hemorrhage in placenta previa. Invasive obstetric procedures. External cephalic version. You turn the baby from breech presentation to cephalic presentation. Cesarean section or trauma. Lack of perinatal care. So these are the risk factors and causes which lead into Rh immunization. Transfusion of an Rh negative female with Rh positive blood, which happens very rarely, especially during an emergency, also causes hemolytic disease or Rh immunization. Sensitization of a mother due to formation of anti-D immunoglobulin, these IgG antibodies can cross the placenta and cause hemolysis, causing severe fetal anemia, hyperbilirubinemia, which can lead into neurological damage and death. So this diagram is nicely describing when Rh positive father married to Rh negative mother, where so first Rh pregnancy is generally unaffected, even though the baby is Rh positive. Mother does not have antibodies. Therefore, first Rh positive pregnancy is generally not affected. Crossover of blood of Rh positive baby into maternal sites during delivery builds the sensitivity. Anti-Rh antibodies, IgG antibodies, which remain in the mother forever. So residual antibodies attack Rh factors in the blood of the second Rh positive fetus, which lead into hemolytic disease of newborn. So if you go along this arrow, fetal red blood cells with Rh positive antigen here and maternal circulation of Rh negative mother. Rh positive antigen will be cleared by macrophages, processed and transferred to plasma stem cell precursors, which in turn lead into primary immune response. Primary immune response is low, 6 weeks to 6 months. It's mainly IgM antibodies. They are large antibodies. They do not cross the placenta. So therefore, first baby is not affected. With subsequent exposure, the plasma cell line proliferate and produce humoral antibodies. So that is called secondary immune response, which produce IgG antibodies. These IgG antibodies are relatively small antibodies. They can cross the placenta and affect the Rh positive baby. So therefore, secondary immune response will cause hemolytic disease of newborn. So what are the factors affecting severity of the hemolytic disease of newborn? Level of maternal anti-D, subclass of anti-D, efficiency of anti-D transfer to the fetus, antigen site density on fetal red cells, efficiency of fetal splenic function, ability of anti-D to interact with Fc receptor bearing effector cells, erythropoietic response to anemia, ability of liver to conjugate and excrete bilirubin postnatally, Fc receptor blocking antibodies. So these are the factors affecting severity of hemolytic disease of newborn. So in a summary, if you go through this flow chart, Rh positive father marriage to Rh negative mother. So first baby is Rh positive, but First baby is usually unaffected. Rh positive cells, miscarriages, termination, ectopic pregnancy, amniocentesis, antepartum hemorrhage, delivery of placenta. So these Rh positive cells cross to the Rh negative mother, which lead into Rh antibody production. They pass to the second Rh positive baby, which causes hemolysis, fetal anemia, hydrops fetalis. My colleague described how to handle this hydrops fetalis with postnatal exchange transfusion and phototherapy. Prognosis, the introduction of Rh immunoglobulin has significantly decreased the incidence of rate of Rh hemolytic disease. According to study, the incidence rate of this hemolytic disease declined from 40% to 14% per 10,000 during the first decade of IV immunoglobulin introduction. Mortality rates are still relatively higher in developing countries such as Sri Lanka, involving around 276 infants and neonates per 100,000 live births. So we have to think positively, make our decisions in the process of future. So how to decrease the incidence of hemolytic disease of newborn due to Rh immunization. Complications due to Rh immunization, early miscarriages, intrauterine fetal demise due to hydropic changes, fetal low neonatal anemia, kernicterus, hydrops fetalis. I'm not going into detail management of these things. Rh immunoglobulins, treatment Rh immunoglobulin, it's my job. I will describe how you are going to, use Rh immunoglobulins to prevent, Rh immunization and prophylaxis. Sangeetha described what phototherapy, exchange transfusion, and in utero blood transfusion is not, developed in a country like Sri Lanka, as a fetal medicine is not that developed, right? So the last bit of lecture, right? So I'm not going to exhaust you the Saturday night, right? So please concentrate my lecture from this slide, right? So this is the important part of my lecture. So management of Rh incompatibility, obstetrician's point of view, obstetrician role. So management of Rh incompatibility. So in a nutshell, so this management is divided into unsensitized pregnancy management or sensitized pregnancy management. So when you talk about Rh incompatibility in pregnancy, there are a group of mothers who are unsensitized, who are not having antibodies. There's another group of mothers who are sensitized, who are having antibodies in their blood. So if mother is sensitized, so that means mother is having antibodies. What you are going to do? Anti-D and anti-C levels should be measured every 4 weeks, up to 28 weeks of gestation, and then every 2 weekly until delivery. If the antibody titer rises beyond the critical level, the pregnancy should be monitored weekly by ultrasound scan, specifically assessing the fetal middle cerebral artery peak systolic velocity, because to detect hydrops fetalis. So invasive treatment should be take place, such as fetal blood transfusion. If the middle cerebral artery peak systolic velocity rises above 1.5% multiples of median threshold, or if there are other signs of fetal anemia or fetal hydrops fetalis. Anti-D level of more than 4 international units per ml, but less than 15 international units per ml correlate with the moderate risk of hemolytic disease of newborn. Anti-D level, which are more than 15 international units per ml, can cause severe hemolytic disease of newborn. Anti-C level of more than 7.5 but less than 20 correlate with the moderate risk, but anti-C level more than 20 international units correlate with the high risk. So these are the few figures taken from guideline on Rh isoimmunization management, which will guide us in the management of sensitized mother during antenatal period. For anti-K antibodies present, referral should take place once detected. Severe fetal anemia can occur even with low titers of anti-K. Again, if mother is sensitized, non-invasive fetal genotyping using maternal blood is now possible for DCE K antigens. What is this? This should be performed in the first trimester for the relevant antigen when maternal red cells antibodies are present. So determine fetal genotype non-invasive from maternal blood using PCR technique is the basis behind that. You take a blood sample of mother and extract the fetal DNA from the blood sample and detect what is the Rh blood group of the fetus. Fetal RHD status can be detected with great sensitivity using the cell-free fetal DNA extracted from maternal plasma. So when mother is sensitized having Rh antibodies, if fetus is Rh negative, which is detected by cell-free fetal DNA, where it is extracted from maternal plasma, there is no risk because the baby is negative, even though mother is sensitized. Your headache is over. So non-invasive prenatal testing, which is available in Sri Lanka, involves a simple blood screening that uses the DNA. It's called cell-free fetal DNA to analyze baby's risk for number of genetic disorders. But unfortunately, this non-invasive prenatal testing, in short form we call NIPT, which is not available in our government health sector. It is available in the private sector, but it's very expensive. So going into a few flowcharts at booking, all pregnant women should be screened for ABO and Rh system. Clinically significant antibody screening positive. So the pathway I have already explained. Test monthly until 28 weeks, test 2 weekly until delivery. All other clinical significant antibodies consider paternal fetal genotyping, which is not freely available in Sri Lanka. So if the Rh antibodies are no clinically significant antibodies, so you need to repeat testing at 28 weeks. Right. So the last part of the lecture to discuss about Rh immunoglobulin, which change the hemolytic disease of newborn incidence globally. So Rhd immunoglobulin is a commercial biological antibody derived from human plasma that targets the red cells positive for Rhd antigen. It is used in preventing hemolytic disease of fetus and neonate. If the Rh negative mother forms anti-D antibodies, this is known as Rh immunization. These maternally derived anti-D antibodies may cross the placenta and target the Rh positive fetal red blood cell for destruction and result in hemolysis. This hemolytic disease may have devastating effects on the fetus, as we described throughout this lecture. So Rh immunoglobulin, it has the ability to coat the fetal red blood cells having surface D antigen, making antigen antibody complexes that move across the placenta before activation of the maternal immune system. However, the dose adjustment can be done according to the degree of hemorrhage by estimation of fetal red blood cells in maternal circulation with a test called Cly-Harbour acid elution test. So the Cly-Harbour acid elution test will detect the amount of fetal blood which has crossed towards the mother. So if we can use anti-D immunoglobulin to neutralize the red blood cells of fetus which has crossed from baby to mother, so that is the idea of prevention of Rh immunization. In a case of abortion, which occurs less than 13 weeks, a mini dose of 250 international units should be given and complete the standard dose in case of miscarriage. It has a short half-life of 3 months. It is given once during 28 to 32 weeks antenatally, then in the postpartum period within 72 hours hours after birth, the baby standard dose is 1,500 international units for every 30 ml of fetal blood exposed to maternal circulation. What is the mechanism of action of this magic drug immunoglobulin? The mechanism of action for patients receiving Rh immunoglobulin, anti-D immunoglobulin in immune thrombocytopenic purpura not entirely understood, but prevention of Rh IC immunization appears to be immunologic blockage of FC receptor within the reticuloendothelial system. Administration of anti-D into Rh positive recipient leads to antibody coating of the circulating erythrocyte, which are eventually cleared primarily by the spleen. Clearance of sensitized erythrocyte by reticuloendothelial system resulting in increased platelet count and reduced bleeding. So if administration occurs within 72 hours of full-term delivery, the incidence decreases markedly from 12 to 13% to 1 to 2%. Right? So these are the list of indications which I have already discussed. So sensitizing events where we use anti-D immunoglobulin to prevent Rh-IC immunization. I'm not going to discuss again. So this small table nicely described. So the indication for anti-D immunoglobulin. So when there is an miscarriage occurs, which is less than 12 weeks, when there is a miscarriage occurs 12 to 20 weeks and greater than 20 weeks, right? So different dosages, how we are going to use anti-D immunoglobulin to prevent Rh-IC immunization. So coming to the last bit of lecture, antenatal prophylaxis, something we should pressurize to our system to introduce into our antenatal mothers. It is not yet introduced into our health sector, government health sector, even though in the private sector in practice. All D negative pregnant women who have not been previously sensitized, whose Rh antibody levels are negative, offered routine antenatal prophylaxis with anti-D immunoglobulin. So that is the step which has dramatically reduced the mortality rate, morbidity rate due to hemolytic disease of newborn. A single dose regime at around 28 weeks, which we commonly use in the private. Two-dose regime given at 28 to 34 weeks. So administration of Rh immunoglobulin as soon as possible and always within 72 hours of postnatal sensitization when that is happening, that is recommended in our system. So Rh immunoglobulin should be administered within 72 hours of delivery. So that is the coming to my lecture. So we have time, we will be in the system, so we can answer any questions if participants have anything unclear about Rh-IC immunization.
Ruwan, thank you very much for that very explanatory lecture, and also Sangeetha. Actually, the question that I wanted to ask you at the end, you answered. My question was if the mother has already sensitized, and what is the place for program or anti-D antibodies?
There's no place. There's no place.
Yeah. So I think that's one very explanatory. It's a very basic thing that you explain in detail, both of you. Thank you so much. I have something to add for the audience. If you have any baby who is suspected of having some kind of hemolytic disease, and if you have suspicion, if there's a background for Rh incompatibility or ABO incompatibility, and if the baby is jaundice within 24 hours, and you need to attend to this baby very urgently, and you should start phototherapy and start working on this baby, treating on this baby, and monitoring this baby actively, and preferably better to admit this kind of babies with significant evidence of hemolysis rather than keeping in the postnatal ward. We always try not to separate babies and mothers, but this is one situation where you have to monitor these babies very vigorously, because we have had bad experience with keeping these babies in the postnatal ward and doing serum bilirubins and not chasing the bilirubin levels, and later on you find the baby with exchange level bilirubin. So babies with high degree of hemolysis, highly suspected babies with past history of similar incidents, maybe the previous pregnancies, and please pay your attention. And this is life-saving. And if you miss it, it's going to cause brain damage, and it is permanent. And thank you very much, Ruwan and Sangeetha, for this very important explanatory lecture. Thank you, everyone, for participating.
Thank you very much, sir. Thank you very much for inviting us.
So there are two questions in the chat box and the Q&A.
Yeah.
One is about what is the current evidence for the vaccination following immunoglobulin treatment for jaundice. So actually, as for my reference, I couldn't find exact evidence for this kind of vaccination delays. Only a Canadian guideline, they have mentioned that after a IVIG infusion, that also depends on the dose that we use. So 0.5 to 1 gram per kg is a bit of a quite higher dose. So if you are using a higher dose, they recommend to delay the live vaccines nearly 5 to 8 months duration without giving it, just because there is no interactions with the BCG or any other kind of live vaccine with the IVIG. But the problem is with the immunity, the efficiency of the vaccine. So the efficacy of the vaccine will be reduced if you are giving immediately after IVIG dose. That's what the studies have found. So, sir, I have no much of a clear idea actually how many months that we have to delay after the IVIG, although the evidence say 5 to 8 months.
Yeah.
So what can we practice?
There's, as you said, there's no much of evidence for that, Sangeetha.
Yes.
And what we practice is we delay all the live vaccines 3 months. From if treated with IVIG, we delay 3 months in our day-to-day practice. But as you said, there's no evidence for this.
Yes.
As you said, effectiveness could be affected, but nothing will happen. Even if you give the vaccine, nothing will happen to the baby. But the only thing, the effectiveness of the vaccines can get affected with live vaccines.
And the other question someone is asking is the usage of triple phototherapy in the management of neonatal jaundice. So none of the guidelines, there are no recommendation for a thing called triple phototherapy. So that is double surface phototherapy, that is to increase the surface area that we are providing the intensive phototherapy to. So the recommendations for the double surface phototherapy. The triple means we are putting multiple lights. Probably that will increase the surface area that we are providing phototherapy to. So from any multiple sites, if you are exposing the baby to phototherapy lights, definitely there will be increase in the intensity. So I think someone will agree with that. So there are no recommendations for triple phototherapy as such.
Yeah, it's in the literature it doesn't talk about the word triple, but extensive phototherapy. Extensive phototherapy may be used when you are having troubles, when you are having difficulties in controlling serum bilirubin level. So even the practice of using multiple lights is practiced everywhere. But what is important is when you start phototherapy, you have to. This is for the audience and the nurses and the junior doctors. The distance between the light and the baby. That is something that you need to be very careful. Because I have seen many times, even in the private sector, keeping the lights very high up, and then finally you find the bilirubin. Be worried about keeping the phototherapy, because now we are using, most of the time we are using LED phototherapy, so it's not going to cause any damage to the baby or other temperature problem. So use the proper gap between the light and the baby. Another thing is turning the baby. You need to keep turning the baby when the baby is under phototherapy. The third thing is you need to dress the baby in the proper way when the baby is under phototherapy, and not to use a big, larger nappy or the pampers, which covers almost 50% of the baby. And also some people use a hat to cover the eyes. So these are the things that we should avoid. Use an iPad and use a smallest nappy or the pad just to collect urine and stools, so that you have a larger surface area for the phototherapy. And while on breastfeeding, if you are continuing breastfeeding while on phototherapy, you can turn the light to the when the baby is being fed with the mother, and that also gives some kind of continuation of phototherapy.
There's another question asked: do we have to give IG for threat miscarriage in first trimester? Let me answer that question. So first trimester is defined as, first 12 weeks. First 12 weeks. So within first 12 weeks, threat miscarriage where we experience spotting, mild vaginal bleeding, no need. But if bleeding is heavy, there is a place for anti-D immunoglobulin. If there is an ectopic pregnancy, if there is a termination, if there is surgical management, or if there is medical management, there is clear evidence, there is an indication for anti-D immunoglobulin.
Any other questions in the chat box?
So there's another question. What is the effective double phototherapy?
Well, people used to call double phototherapy for 2 lights actually, but if you can have the double surface phototherapy, one below the baby and one above the baby, that will be more effective, because then you cover more surface area. So there are new phototherapy, and even in the past we had very old type phototherapy with double surface, one light under the baby and one light above the baby. But now the latest is there's something called 360-degree phototherapy, where you have it's like I'm sure you may have phototherapy chamber where baby gets phototherapy from 360 degrees. So double surface ideally means one from the top and one from the bottom. That is what is meant by double phototherapy by definition. This is double surface phototherapy. But when you start 2 lights from top, people used to call it double phototherapy. But I don't find any, that's okay as long as you use more lights. But these are not, there are not definite definitions for this double phototherapy or triple phototherapy. Those are common terminology used by many people. What is important is many lights as possible when you are in trouble with improving of if the bilirubin level is not improving, and try your best to give maximum effective phototherapy and prevent the baby going under exchange transfusion. And exchange transfusion is very rare now because of the effective phototherapy, and we hardly do exchange transfusion. So phototherapy is very effective, extremely effective. So using many lights, I don't find any problem with using many lights. And we use 3 lights, 4 lights, and we have been successful always.
We have another question to Dr. Ruwan Silva. What is the theta of antibody to start MCA monitoring?
So that is depend on the if it is anti-D, right? Anti-D, it should start when there is a moderate risk of hemolytic disease of newborn. So that is where the levels are more than 4 international units. We come to anti-C. So the risk is moderate risk of hemolytic disease of newborn, where the theta level is more than 7.5. So that is the theta level, 4 international units in anti-D or 7.5 international units in anti-C. So we start monitoring baby for hemolytic disease of newborn, such as major cerebral artery Dopplers, to identify hydrops fetalis.
Somebody has raised the hand. Any other questions? Okay, I think there are no more questions. So I think shall we wind up?
Yes. Yes.
Thank
you very much, Dr. Ruwan Silva and Dr. Sangeetha Wickramarathna, for your valuable contribution for today's clinical session. Good night, everyone.
Thank you.
Thank you.
Thank you.
Thank you, Ruwan.
Thank you.